Hello, I'm Dr. Jonathan Silverberg. I'm an associate professor of dermatology at the George Washington University School of Medicine and Health Sciences. And today I'll be discussing epidemiology of alopecia areata and its comorbidities. For background, these are my disclosures. None of these should be relevant to anything I'll be discussing today, although I will certainly do everything I can to give a fair and balanced presentation. So let's get started and talk about the epidemiology of alopecia areata. So there have been a lot of different studies conducted in a lot of different regions, a lot of different time points, a lot of different patient populations. And so we really wanted to try to pull all the data together and synthesize that data to give some more meaningful and tangible estimates with respect to the epidemiology of atopic dermatitis. And so these are the results of a recent systematic review and meta-analysis that we published in the Journal of the American Academy of Dermatology with a comprehensive search strategy that identified almost 100 studies that were included in the systematic review. So I'll first start by presenting that overall pooled prevalence estimate across all study designs, all studies, all time points, et cetera. And the number is about 2.1% for an overall global prevalence of alopecia areata. Now, we recognize that most of those cases are likely going to be milder or patchy cases. And in fact, when we did pooled estimates for those who had alopecia totalis, we found a pooled prevalence estimate of 0.08%. And for ophisis pattern is the rarest subset I've observed of 0.001%. And for alopecia universalis, 0.03%. So certainly less common than the overall prevalence being fairly high. Now, it turns out that the prevalence of alopecia areata has significantly increased over time. When we look at studies that were conducted before 2000 and compare them with studies that were done in 2000, 2009, and then after 2009, we see a stepwise increase over time in the prevalence estimates observed across those studies. Likewise, when we look at studies that examine the prevalences of alopecia totalis and universalis, we see a similar phenomenon of significant increases of prevalences of those subset over time. Now, it turns out that there's significant differences based on the population study. So the clinic-based studies have markedly higher prevalences overall compared to the population-based studies. Now, you have to interpret this with a grain of salt because the clinic-based studies likely overestimate, not likely, certainly overestimate the prevalence because there's a referral bias, right? Who's going into a dermatology practice? Patients with skin disease, right? On the other hand, previous studies have shown challenges with really being able to identify alopecia areata in population-based studies. And so the population-based studies likely underestimate the prevalence of alopecia areata. So the true prevalence probably lies somewhere in the middle and probably closer to that 2.1% overall prevalence. Although more research certainly needed to better flesh out what that population-based prevalence is and what proportion of patients out there are actually coming in to be seen for their alopecia areata. There were also significant differences observed in terms of prevalence by region, with the highest prevalences observed in studies conducted in Africa and South America. Some of this needs to be interpreted cautiously because it may be confounded by study design, where there may be more clinic-based studies which have that higher prevalence compared to the population-based ones. But we also saw a similar pattern for prevalence of alopecia totalis being significantly different and higher amongst North American patients compared to studies that were done in Asia. Interestingly, the prevalence of alopecia areata was higher in studies of children and adolescents compared to those that were adults. Now, this is interesting because some studies have suggested that the prevalence should be higher in adults than children. Some of this, again, may be confounded by differences in terms of being more clinic-based studies done in the pediatric population, but there may be, there may be something to this, or at the very least, it suggests that alopecia areata in the pediatric population is not as rare as some assume it is, and may require much greater attention, certainly as much attention as the adult population would require. Here we also saw higher prevalences of alopecia areata observed in studies that had a predominance of males compared to studies that had a predominance of females. And I want to clarify this. Unfortunately, very few studies have really stratified prevalence estimates by amongst their female populations versus their male populations. So we really don't know if there are sex or gender differences in the prevalence of alopecia areata. What we were able to do was, though, to look at the characteristics of the overall cohorts of the study and say, okay, which studies had a predilection, more than 50% of their patients being female or more than 50% of their patients being male. And amongst those studies that had more males in their cohorts, there were significantly higher prevalences observed. Whether or not this will translate into true sex or gender-based differences in the prevalence of alopecia areata, we don't really know yet, and future studies are certainly warranted to sort some of this out. And last, we were able to see higher prevalences amongst persons with autoimmune disease. So patients in particular who had systemic lupus erythematosus had markedly higher prevalences of alopecia areata compared to those with psoriasis, close behind vitiligo, which were markedly higher than those who did not have autoimmune comorbidities. So a lot of variability and a lot of different factors that seem to be driving the prevalence of alopecia areata. Now, this last subset of autoimmune comorbidities, I think, segues nicely into the next section of the talk, which will address the comorbidities of alopecia areata. So first, we'll start with atopic dermatitis. And these are the results of a systematic review and meta-analysis that my group published several years back that looked at the relationship of atopic dermatitis with either vitiligo or alopecia areata. And there was a comprehensive search strategy employed. 16 studies identified for vitiligo, 17 studies for alopecia areata, and a subset of those with adequate data for pooled meta-analysis. And what was found was significantly higher odds of both vitiligo and alopecia areata in terms of being related to atopic dermatitis. Now, interestingly, the higher effect size was observed for vitiligo compared to alopecia areata, but in fact, there were significantly higher odds with an odds ratio of 2.57 for atopic dermatitis and alopecia areata being related to each other. And in particular, amongst those studies that stratified by the alopecia totalis and universalis, it turns out that there were significantly higher odds of alopecia totalis and universalis compared to pouchy alopecia with atopic dermatitis. So more severe alopecia areata in patients with atopic dermatitis. And we see this anecdotally, and other individual studies have shown that the vitiligo and the alopecia areata are often more severe when accompanied by atopic dermatitis. And conversely, the atopic dermatitis is often more severe when accompanied by vitiligo and alopecia areata. Now, what about allergic disease? And this is where it gets a little bit more tricky, a little bit more mixed results. So first, I present the data from a retrospective clinical study conducted in Boston that looked at over 2,000 alopecia areata patients and found that 38% had one or more atopic comorbidity, including allergic rhinitis, asthma, atopic dermatitis. And that was a higher prevalence than previously observed for atopic comorbidities amongst the psoriasis population from that same cohort. On the other hand, there's another study, it was a prospective survey study of over 500 alopecia areata patients that found that alopecia totalis and universalis was associated with higher rates of atopic dermatitis compared to pouchy alopecia, but not asthma or allergic rhinitis. And I think that's very interesting because it may be that there's something specific about the atopic dermatitis that is associated with alopecia areata and not just the atopic diathesis in general. Certainly more studies are needed, and those studies really need to parse out when is it the skin disease, the atopic dermatitis, versus when is it the atopic diathesis. Now, it's very interesting because that meta-analysis that I showed you earlier and those studies that I've showed you earlier about the relationship of atopic dermatitis with alopecia areata, most of these were cross-sectional studies. So it makes it challenging to know, we can know there's an association, but we don't necessarily know the temporal relationship of those associations. And here I present a recent study that examined exactly that. What is the direction? Is it that the atopic dermatitis causes alopecia or precedes and leads to alopecia areata, or vice versa, that the alopecia areata is a risk factor for atopic dermatitis? And the answer is, from this study, yes, both of those are true. So this is a longitudinal population-based cohort study using a health insurance database from Taiwan Now, there's always some challenges about classification bias from those kinds of health insurance databases, but there's a very large, well-powered longitudinal cohort and well-designed matched control subset of patients. In their first analysis, they looked at whether or not alopecia areata was a risk factor for atopic dermatitis. And what they found was that patients with alopecia areata had a 5.5-fold higher risk of atopic dermatitis and a shorter time to occurrence of atopic dermatitis than the control patients. And conversely, patients with atopic dermatitis, in their second analysis, had a 6-fold higher risk of alopecia areata and a shorter time to occurrence than alopecia areata than the controls. So we're seeing this bidirectional relationship of atopic dermatitis with alopecia areata and vice versa. Now, it turns out that it's not just about the atopic comorbidities, and there's now increasingly recognized associations with mental health comorbidities. So these are the results of a recently published systematic review and meta-analysis that identified 17 studies in the systematic review, 8 studies to include in the meta-analysis. And this study sought to understand the relationship of atopic dermatitis, of alopecia areata with anxiety and with depression. And what was found, and what you see on the forest plot on the left is anxiety, the forest plot on the right is depression. Before we even look at the pooled associations, we see individually the studies that really most of these individual studies found associations of alopecia areata with anxiety and similarly with depression. But when you pool them together, certainly you see this association with an odds ratio of about 2.5 for both the anxiety and for depression. And I think the mental health associations are very important. This meta-analysis really looked at these studies, most of which were cross-sectional, but I think from my own anecdotal experience and from the few studies that have looked at the temporal relationship, that there is a bidirectional relationship between alopecia areata and the mental health comorbidities. Certainly, alopecia areata is exceedingly anxiety-provoking and induces depressive symptoms. Patients are very distraught over their appearance and the impact of their disease on quality of life. On the flip side, we know that stress, anxiety can be a major trigger for alopecia areata to de novo or even to be exacerbated. So even here, we expect there to be a complex bidirectional relationship. Now, it turns out it's not just anxiety and depression. So these are the results of a study that my group conducted to examine the relationship between mental health hospitalizations with alopecia areata. And we used data from the nationwide inpatient sample, which is a representative 20% subsample of all US hospitalizations in the United States. And what we found was that hospitalization for mental health disorders was significantly increased overall for patients who had diagnosed alopecia areata, but in particular, adjustment disorders, anxiety disorders, mood disorders, which would include depression, personality disorders, schizophrenia, alcohol-related substance abuse, etc. So a whole gamut of mental health comorbidities being related to alopecia areata and specifically mental health hospitalizations. The risk factors observed for mental health hospitalization in alopecia areata included middle-aged adults, male sex, white race, hospitalization in a rural community, greater number of chronic diseases, and those who had no or public insurance. And some of this may be proxy measures of more severe disease or more uncontrolled disease. And this is something that certainly warrants further investigation. More recent studies that have shown provocative associations of alopecia areata with cardiometabolic comorbidities. So this is a study done in the United States, a cross-sectional study of millions of patients from over 360 hospitals in the United States, and very well matched between the alopecia areata patients and the control patients. And what they found was that significantly higher odds of observed for the alopecia areata patients for hypertension, obesity, hyperlipidemia, diabetes, metabolic syndrome, coronary artery disease, AFib, and stroke. And the only thing they didn't find association with was myocardial infarction. So these are very important associations. And certainly, we don't really know all the mechanisms as to why this is happening, and something that definitely warrants further research. Now, it turns out that these associations are not unique to adults. And I think these are even more provocative data, because we certainly don't think of metabolic disease as being a major issue in children. But what we're seeing is a study from that same cohort, but focusing it on the pediatric population, that found higher prevalences of a variety of different disorders in the alopecia areata patient population. So atopic dermatitis, as we would expect, vitiligo, psoriasis, lupus, thyroid disease, celiac, rheumatoid arthritis, juvenile idiopathic arthritis, and ulcerative colitis. And then when we look at the metabolic disease, higher rates of obesity, hyperlipidemia, diabetes, and metabolic syndrome. And other miscellaneous disorders as well, like hypothyroidism, depression, vitamin D deficiency, and anemia. So fascinating. And part of this may be from just maybe not specific and related to chronic debilitating disease in general, versus some of this may be very specific and related to the systemic inflammation that happens in this disease. And I think future research is certainly warranted to better understand this. So to summarize, the prevalence of alopecia areata appears to be increasing and varies by sex, by study design, and by region, although many of the aspects of the epidemiology of alopecia areata really remain still uncertain. Alopecia areata is associated with a variety of atopic comorbidities, although it really seems like the dominant one is atopic dermatitis, although, as I mentioned, mixed findings for the other atopic comorbidities, but it is associated with a variety of mental health disorders, even hospitalization for mental health disorders, as well as a variety of cardiometabolic comorbidities in both children and adults. And I think future research is certainly warranted in terms of better understanding opportunities for primary prevention and secondary prevention for alopecia areata and subsets, as well as how do we best address and mitigate all of these different comorbidities in the alopecia areata patient population. And with that, I thank you for your attention and turn the podium over.